Hello and welcome to Pharmacy Skills. We're looking at the cardiovascular system in this course, and this chapter focuses on drugs for arrhythmias. Drugs used in arrhythmias are known as antiarrhythmic drugs, and it can be classified according to those that act on supraventricular arrhythmias, in other words, arrhythmias originating in the atria, or those that act on both the supraventricular arrhythmias and the ventricular arrhythmias. And then we have those that act on the ventricles. Now we will explore the three groups. Adenosine is usually the first choice for supraventricular arrhythmias because it has a very short duration of action, a half-life of about 8 to 10 seconds, and most side effects are short-lived. However, the half-life of adenosine can be increased if you're also taking dipyridamole. Another one is verapamil. Verapamil, also known as a rate-limiting calcium channel blocker. However, because of the additive effect with beta blockers, patients on verapamil will be contraindicated from taking verapamil if they're already on beta blockers. Verapamil is preferred to adenosine in patients with asthma, so that's worth noting. Verapamil also widens the QRS complex. It can cause hypotension, but it is an effective and a powerful drug for controlling arrhythmias. Next is cardiac glycosides. The main ones, or the only ones talked about in the BNF, is digoxin. It can be used for supraventricular arrhythmias to slow the response of the ventricles. However, it acts way too slow to be used for rapid control. Next is intravenous or IV beta blockers such as esmolol and propranolol. These can be used to control ventricular response to supraventricular arrhythmias. Again, all these drugs I'm discussing right now are for the supraventricular arrhythmias. It's important to note here that both adenosine and verapamil are contraindicated in conditions associated with something known as the conducting pathway. For example, Wolff-Parkinson-White syndrome, which you've probably seen that in the BNF. What this condition means is that while normally the heartbeat would go from atria to the AV node and then could be conducted down to the ventricles, people with any accessory conducting pathway condition, they have an alternative route. It means there's an additional pathway for the electrical current to travel down rather than the normal ventricle AV to the ventricles. It goes down another pathway. Now, when the electrical current behaves in this way, it can throw off the rhythm of the cardiac cycle. Now we'll consider drugs that act on both supraventricular and ventricular arrhythmias. Amiodarone. Now, amiodarone can be used for both ventricular and supraventricular, particularly when other drugs have been ineffective or are contraindicated. It can also be used in accessory pathway conditions, unlike the drugs we discussed earlier on, but it should only be initiated in a hospital situation by a specialist. IV amiodarone can be used for rapid response. It also has the advantage of not causing myocardial depression. Amiodarone can also be used in pulseless tachycardia. It has a very long half-life and only needs to be taken once daily. Beta blockers can be used in both arrhythmia types as well. They act by reducing the effects of the sympathetic nervous system. The next drug is disopyramide, which is another drug that can be given by IV to control rapidly arrhythmias after an MI. But it can reduce the contractility of the heart, and to be careful, if given orally, disopyramide has antimuscarinic effects and which can limit its use in patients with glaucoma or prostatic hyperplasia. The next drug in this class is flecainide. Flecainide may be of value for serious symptomatic ventricular arrhythmias. And then another drug is propafenone. Propafenone is used for prophylaxis of arrhythmias. Another drug is mixelotine and procainamide. Now, mixelotine and procainamide need to be obtained through special order for patients with life-threatening arrhythmia. Now, the last group is drugs for ventricular arrhythmias. Lidocaine. Lidocaine can be used in hemodynamically stable patients, but it is not the drug of choice anymore. Drugs that work for both ventricular and supraventricular, like propafenone, beta blockers, disopyramide, and flecainide, and procainamide, are the ones which are now commonly used for ventricular arrhythmias.